This session is dedicated to the latest evidence from big trials. And it is when you speak about trials, you cannot have a chairman that is better than Patrick, like we have. So in this session, we have also as panelists Tanveer, François, Derimay. Yes, welcome. I didn't see you before. Jean-Louis Gutiérrez-Chico, Petr, Okan, Turgut, and Krunal, Tamakuwala. Okay, so we start. Do you want to introduce the first one?
Yeah. So it's, of course, the famed tree, bifurcation substudy by Daimy Dillen.
Well, thank you for the introduction. Good afternoon, everyone. It's my pleasure to present to you the impact of bifurcation lesions on outcomes after FFR-guided PCI or CABG. In the syntax era, including PCI with first-generation drug-eluting stents and only angiography guidance, the presence of a bifurcation lesion in patients with three-vessel disease has emerged as an important factor to choose for revascularization with CABG rather than PCI. This is because PCI in these patients was associated with higher adverse event rates, including mortality and revascularization, when compared to CABG, which circumvents these bifurcation lesions. But what about contemporary PCI? Because there have been some considerable improvements in PCI since the syntax era, such as FFR to guide the procedure, the use of second-generation drug-eluting stents, and the use of modern bifurcation PCI techniques. This could all potentially lead to improved outcomes in patients with three-vessel disease and a bifurcation lesion treated with PCI. And that's what we wanted to investigate. And to do this, we performed a sub-study of the FAME-3 trial. The FAME-3 trial was a randomized controlled multi-center trial comparing FFR-guided PCI with CABG in 1,500 patients with three-vessel disease not involving the left main. For this sub-study, we compared patients with at least one true bifurcation lesion, defined as Medina 111, 101, or 011, with patients without a true bifurcation lesion. And the primary endpoint was the composite of death, MI, or stroke at 3-year follow-up. Here you can see the baseline characteristics of patients with at least one true bifurcation lesion and patients without a true bifurcation lesion. And we see our typical cardiovascular disease patient with a mean age of 65 years old and predominantly male. Almost all baseline characteristics were not significantly different between both groups. Only the syntax score was higher in patients with at least one true bifurcation lesion compared to patients without a true bifurcation lesion, what is to be expected. Here we show our first results. You can see a Kaplan-Meier curve for the composite of death, MI, or stroke at 3-year follow-up. And the patients are divided into 4 groups. Patients treated with FFR-guided PCI and with at least one true bifurcation lesion, patients treated with FFR-guided PCI and without a true bifurcation lesion, patients treated with CABG and at least one true bifurcation lesion, and patients treated with CABG and without a true bifurcation lesion. And you can see that there was no significant difference in the combined endpoint at 3-year follow-up with a P of interaction of 0.81. And here you can see a forest plot. And you can see that in patients with at least one true bifurcation lesion, there was no difference in the composite endpoint of death, MI, or stroke at 3-year follow-up between treatment with FFR-guided PCI or CABG. The same applied for patients without a true bifurcation lesion, as there was no difference in the 3-year incidence of death, MI, or stroke between the patients treated with FFR-guided PCI or CABG. This is a big outcome table. It shows all the combined and individual endpoints. But the most important thing about this table is that there were no significant differences in all the outcomes between patients with at least one true bifurcation lesion and patients without the true bifurcation lesion after both FFR-guided PCI and cabbage. Then, in the patients with at least one true bifurcation lesion in the FFR-guided PCI group, about 65% of those patients had at least one FFR-positive true bifurcation lesion, which was defined as a positive FFR in the main vessel. The other 35% had an FFR-negative true bifurcation lesion. When we compare those groups, we can see that there was no difference in the combined endpoint, again, for death, MI, or stroke at 3-year follow-up between patients with at least one FFR-positive true bifurcation lesion or patients with an FFR-negative or no true bifurcation lesion. And when we take a look at the stenting strategies in for the bifurcation lesions in the FAME3 trial, we looked at it with the patients with at least one FFR-positive true bifurcation lesion. You can see that only 7.5% of those patients were treated with two-stent strategy. Far most patients were treated with only one stent, as the protocol of the FAME3 trial described to treat the bifurcation lesions using the provisional stepwise approach. When we compare this to the Syntax trial, you can see that more patients, about 30%, were treated with two stents. On the right side, you can see the two-stent strategies that were applied in the FAME3 trial. And despite the protocol advising to start with a stepwise provisional approach, more than 50% was treated with a crush strategy. And thereafter, the top or T-stenting or the culottes were used most. And I think that's where we also can see in the Syntax trial, mostly used techniques were also the crush, culotte, or the T-stenting, but also V and Y stenting were used a little bit more when we compare this to the FAME3 trial. There are some limitations about this sub-study, because the FAME3 trial was not powered for comparisons between subgroups, and therefore the results of this study should be only hypothesis generating. Left main bifurcation lesions were excluded in the FAME3 trial, so the results of this study could not be generalized to all types of bifurcation lesions, and only about 13% of patients with a bifurcation lesion in the FFR-guided PCI group, and even less, about 10% of patients with a true bifurcation lesion in the FFR-guided PCI group were treated using intracoronary imaging. And we know from the October trial that maybe increased use of intracoronary imaging could have potentially led to even more improved outcomes in patients with a bifurcation lesion treated with PCI. But all in all, I think we can conclude that in patients with 3-vessel disease, the presence of a bifurcation lesion is no longer an important consideration when choosing between contemporary PCI or cabbage. And we attribute these favorable outcomes to the use of second-generation drug-eluting stents, the use of FFR to guide the procedure, and the use of modern bifurcation PCI techniques with provisional strategy as default. And our results were published in Circulation Cardiovascular Intervention earlier this year. Thank you.
Thank you for the presentation. I think that this is the typical environment to discuss this sub-study coming from a big trial, because, I mean, this is really the... So, Patrick, first question is for you. Are you convinced, since, I mean, you know very well the Syntax cohort, that these data are really related with the improvement in our way of treating the bifurcations? I mean, physiology guidance, more use of provisional, or?
No, I think that I review a lot of paper. I did not review yours, and I didn't read it. But the question that I have immediately is what all the journal is asking, is that predefined? That's the first things you have to do. And you have to say, no, it's post-hoc, okay? And then you get some degradation in the value of your paper. So predefined, you lose the power, because now there are 4 groups. So there is only on the slide a p-value for interaction, which is 0.83, if I remember. So I try to understand a little bit better the granularity of the trial. When you have a bifurcation, okay, do you engage the wire in the side branch in the main vessel? That's my first question. The second point, I didn't see on your side the functional syntax score, which is something that NAM introduced in 2011, if I remember. So that's I'm a little puzzled that you are back to the anatomy. I found that the functional syntax score was such a beautiful thing. Any possibility to get an answer?
Yeah.
Before you answer, I mean, it is very tough to have this question, so you are very young, but Professor Serruys should.
Yeah, you mean the FFR wire in both the main vessel and the side branch? Yeah, that's a really good question, because no, not in all bifurcation lesions. Only, I think, in about, of all the FFR positive true bifurcation lesions, so the positive FFR in the main vessel, of those, only about 30% did also measure the FFR in the side branch. So it was not measured at all times, no.
So basically, when you are in a bifurcation, you cross to the main vessel, distal, and if it's above 0.8, you don't treat the bifurcation? That's how you did that? Yeah.
Exactly.
No, and it has probably a certain value, the result, yeah. But next step is to do predefined or another randomized trial.
Questions from the panels? Okay, Goran, sorry.
Yeah, sorry, just a question for Prof. Serruys. In syntax 10-year follow-up, PCI bifurcations 10% absolute increase in total mortality if treated percutaneously, absolutely no difference if revascularization is done by surgeon. How can you put these two studies in the perspective?
Yeah, you know, the trial that we always want to do is QALYs. You do something, surgery of PCI, you wait 10 years, and 10 years later, if you are alive and playing golf, it's good, period. And it took me a long, long time to convince Greg Stone to do that. But now Greg Stone with Godino are doing that kind of trial, long follow-up. And because, you know, all the small detail that I get a drain bleeding, I get a thrombose of one stent, at the end of the day, if it is nothing related to survival, and you are okay 10 years later, as I say, still playing golf, then it's fine. That's the goal in life, is to be alive and play golf, yeah?
Last question.
Just very quickly, because we ran out of time. I'm not sure whether the interpretation should be so optimistic, because actually what we did is like a subgroup analysis. We made 4 groups out of 2, and then we lose the power. So the point of not reaching statistical significance should not be interpreted as, well, now we are equivalent to surgery. Actually, you depicted very nicely in the graphics that the surgery still tends to be better. Yeah,
exactly. I think that's a really, really good point, especially in patients with a high syntax score, patients with diabetes or so. I think that cabbage is still better, but maybe, yeah, I think when a patient does have a bifurcation lesion, I mean, you have a patient, a little bit older patient, low syntax score, no diabetes, maybe those patients, the bifurcation lesion is no longer a factor to choose for cabbage.
Thank you very much. Thank you to the FAME3 investigators for allowing, to discuss with us the results. Thank you.
Thank you.
We move forward. I invite Evald Christiansen, and he will report on the October trial, the left main subgroup, a very hot topic here.
Thank you very much for the invitation to Amsterdam and EBC. And this presentation is a good example of how you lose the power when you look into a subgroup. And therefore, I want you to focus on the hazard ratio rather than p-values and the confidence intervals. So the left main subgroup of October comes from the main trial, where the main trial showed a benefit of using OCT versus angio, 14.1 event rate versus 10.1 in favor of OCT guidance. And as you know, it led to the 1A indication in the guidelines for using imaging in true bifurcation and left mains. So we know that unprotected left main PCI is associated with worse outcome than cabbage. You see the curve to the right, and this year at TCT, I will share with you the 10 years follow-up of the Noble trial. We also know that IVI PCI is associated with better outcome than angio alone. We also saw that in Noble. You see the figures of 19 and 25% here. So we have some evidence for using IVI guiding in two left main bifurcations. From this meta-analysis of the group of Burzotta recently presented, that putting these data together, the use of OCT guidance in left main was associated with better outcome. The aim of this presentation is to evaluate if OCT guiding improves outcome in distal unprotected true left main bifurcations PCI compared to angiographic guidance alone. It comes from the main trial of 1,200 patients randomized 1-to-1, OCT guidance versus angio guidance, and the primary endpoint was MACE at a median of 2 years. It's cardiac death, ischemia-driven target lesion revasc, or target lesion myocardial infarctions. So it should be a true bifurcation, and they were all true bifurcations in the left main. So this is the profile. We had 147 involvement of the left main in the OCT arm and 149 in the angio arm. But this was in a part due to operators stenting into the left main, treating a LAD D1 bifurcation. So when the indication for randomization was the left main, we had 111 and 116. And of course, we are losing power. And therefore, I want you to focus on the hazard ratio from the left main of 0.7. Is that different in the left main? This group of the left main were well balanced according to clinical presentation, age, and gender, and also for how we treated it, how much stents we put in, and the stenting technique were also similar in the two groups. But focus here that IVUS was not recommended in the angio arm, but it was used in 35% as a bailout, because operators for some reason took IVUS on the table in the angiographic arm. 1 out of 3 was use of IVUS in the angio arm. What about the feasibility? Can we get these OCT pictures in the left main? Yeah, pre-stenting, it was a very high proportion that we had good pictures in the LAD and in the circ and in the left main. During the procedure, we were also very good at checking the position of the rewiring after the first rewiring and the second rewiring in a high proportion. What about after stenting? Also, final OCT in the left, in LAD was good, in the circ was good, but the proximal edge, only 39%, it was visible on the final OCT in the core lab. Distally, it was easy to see the stent edge. So we have a challenge there in the left main. What about stent or lumen expansion? Lumen expansion was quite good, and minimal stent area, we achieved this 13.2 in the left main, 9.4 in the bifurcation core, and 7.6 in the LAD, and 6.6. This is if we compare to the most recent guidelines now, where we have shifted the rule of 5. We add 1 figure in the circ to 6, we add 2 figures in the LAD to 8, and we add 3 figures in the left main. So there is a proportion that do not achieve this stent expansion in October trial that is now the goal in most interventions. And around 5% of the stent struts were malapposed at the final OCT. Unintended stent deformation occurred in a very high proportion in these PCIs. In 1 out of 6 during a procedure, there was an unintended stent expansion, and it was mainly at the proximal edge or the LM body or in the bifurcation. So it's a proximal problem due to guiding catheter collision and due to operators doing abluminal rewiring. And unfortunately, operators, even they were trained, were only able to pick that up in half of the cases and treat it. So we know that there's more possibility of using OCT guidance to see that you have done an unintended stent deformation. And it translates into prognosis. We saw that 24% of those that were not corrected had a MACE. When the operator picked it up and treated it, there were no MACE. And comparing that to the MACE rate with those patients without unintended stent deformation, that was 13%. So OCT should also be used to pick up something you was doing without intention in the left main PCI. Now I'll show you the curves. And of course, the confidence intervals are wide because we have lost the power. So I think it's more interesting to look at the hazard ratio that was 0.7 in the main trial. Still in the left main, MACE was in favor of OCT guidance compared to endo guidance. And to the right, you have the patients that were treated into the left main for some reason, treating a LAD D1 bifurcation, extending into the left main. We know that operators know that are not able to nail the ostium. And the disease does not exist. Osteal disease does not exist if you do imaging. So we have stented into the left main, and still we are in favor of using OCT. Also excluding procedural myocardial infarction, OCT guidance was associated with lower MACE rate compared to angio guidance, still around the hazard ratio that we achieved in the main trial. What about IVUS? If we take IVUS out of the angiographic arm, we still have a favorable outcome with OCT guidance versus angio. But to the right, you can see that IVUS is dangerous. Very dangerous. Never use IVUS in PCI. No, it's because people took on board IVUS when they have problems. I cannot get a balloon into my side branch. Something is going on here. I don't know what's going on. So it's a bias. It's you take the IVUS catheter when you are in trouble, and that's the reason for the high event rate there. So I would like to conclude for you that it was feasible to follow a predefined OCT imaging protocol in patients treated for unprotected left main disease. Expansion and apposition was good in the OCT-guided patient. Unintended stent deformation was identified in 1 out of 6. No events were found after successful treatment, whereas left untreated, the event rate was high. The beneficial clinical effect of OCT guidance reached the same level as the main result of the October trial. I think we should look at appropriately powered studies, long-term follow-up, I agree with the panel, and IDP trials are needed. Thank you for your attention.
Thank you, fantastic presentation. It is open to discussions. Question there? Please take the microphone. Okay.
So, a quick question. Congratulations for conducting this fantastic study. We learned a lot from this. 2 points. Only almost 40% of the proximal edge of the stent was seen with optical coherence tomography, meaning that quite often is likely to not be able to see distortion of the stent during percutaneous coronary intervention with optical coherence tomography because we cannot see the proximal edge of the stent. And the other question that I have is that you mentioned that it's around 7 millimeters squared in the LAD, but it's totally different from the 8 that has been reported in IVUS because OCT comparing to IVUS tends to underestimate, IVUS probably overestimate actually, the lumen dimensions. Did you have the chance to look at the distal reference area and to see what's the stent expansion in this data? Because this will give us a better understanding about the performance of the optical coherence tomography in the final results in this setting.
This is a really good question, and a lot of questions. I'll try to answer them. Yes, we are looking into stent expansion also compared to the minimal stent area, and we will publish that. So it's been looked at. The other question about that proximal edge, remember, it's not the proximal edge of the disease. So we are treating a distal left main. Are we covering the ostium by our stenting technique because we don't want to miss just 2 millimeters? That's one point. Is it really important? Yes, it is important because this is where you get the distortion, the unintended stent deformation. There are tips and tricks how to visualize it. A lot of operators are using 7 French now, and if you take a 6 French guideliner and put it in, you can visualize the ostium and see if you have covered the ostium. What are you looking for in the ostium when it was not diseased from the beginning? You're looking for unintended stent deformation. We recommend the foot, the final optimization with the balloon when you are done. And then I think it's possible to nail the ostium by angiographic guidance, and it's possible to check it with the 6 French guide extension. Otherwise, if you're in doubt, bring the IVUS catheter. Sometimes it's been done. You're treating the distal left main, and you can finalize with the IVUS in the ostium if you're in doubt, but you can also visualize with OCT. Was that answers to most of your questions.
Yeah. I think for
Evald, if I can integrate, I feel that for operators that are using OCT for distal left main interventions, it is advisable that they integrate with some stent enhancement check before they close the procedure. Because stent enhancement by angio, it is possible, and they can fix the problem of unintended stent deformation. So not asking to OCT the response, but integrating with the best angio possibility that is stent enhancement, probably.
Yeah. Yeah, it's also sometimes a problem with the flushing of the left main, that you are stopping the injection too early and you should increase the scan range. There are some technical tips you can use to visualize the proximal edge. Yeah.
Evald, really very interesting data. I was surprised the MACE jump during the first day, probably in both groups. In one group it was around 7 and second group nearly 10%. What was the main trigger for MACE during first day after PCI?
Yeah, I think, of course, some of them were procedural myocardial infarctions, and that's why we also excluded them and showing that the curves get the same separation. I think it's due to the fact that you have more control of the procedure.
Next is the gentleman at the back. Short question and short answer.
Lovely presentation. Obviously, one of the criticisms or one of the kind of observations for many operators of October was the protocol was too complicated. And an average of 6 or 7 pullbacks, which I have to say is my practice. But now seeing other people presenting cases post-October, many people have dropped many of the imaging steps. And yet probably the most provocative element you demonstrate is the risk of abluminal wiring through each element of the procedure. How many runs should we be doing? Are there runs that you can drop from the protocol?
Very, very good comment. We learned something from October that the high incidence of abluminal rewiring makes us bring the double lumen catheter on the table very early.
I have a short question.
Because you also spend a lot of time to correct that one. So just get control of the procedure with a double lumen catheter, and if you're in a provisional state, maybe you don't need all those runs. And the provisional strategy is the strategy to do. You can just do a dep in the side branch, use double lumen catheters, and make life more easy.
The next question, yeah?
The question was related to that, is that in your cases of abluminal wiring, was there a specific strategy, a specific type of two-stent strategy which was associated with more abluminal wiring?
So the first rewiring was not dependent on what strategy you had, because you had to go into the side branch because it was true bifurcation. You had at minimum to do a kiss. So I cannot say that what increases the abluminal rewiring is if you have not modified your calcium good enough. You have a stent that is not adequately expanded, even you do a pot, and you have a jailed wire, and the wire bias towards the jailed wire and the underexpanded stent because of the poor modification. That's predictors of getting outside the stent.
It's a very short question. The OCT is intensively quantified by the investigator and also by the core lab later on, correct? Quantified OCT.
Yes.
Quantified OCT. Is the angiography quantified also?
Yes, we're doing a QCA in the angiographic arm also, and looking in stenosis in the side branches. And
okay.
Yeah.
The next question is that did you try, like the Korean people in JAMA, to correct for the underestimation of the QCA?
No, I don't think we have.
Because you will get another 0.3 millimeter. So they have done a beautiful demonstration of that. Yeah.
What about stent enhancement? What about puff when you are inflating the balloon to know if the stent is on the wall? So did you have a protocol for from the coronary arm?
Best clinical practice, and I can just
What
speak
is
from
best clinical practice?
From my perspective, I have used
best clinical practice is to inflate several times the balloon, because the balloon is undersized as the first attempt. The second time is taking 0.2 millimeters. The third time again 0.2 millimeter.
Yeah.
If you correct the left main with a 5%, Then you can do a puff, the inflator balloon, you do a puff, the contrast is not crossing, the stent is on the wall. So,
but sometimes when you have done,
there are alternatives which were not studied in this trial.
No, but that's a good point. I think that there have been 11 trials, angiography versus IVUS. Only 2 of them has been properly quantified. The first one was Paul Terstein, okay? Visual versus highly quantified IVUS. Yeah, you have some kind of bias there. You should quantify both or use all the technique that you have in-house, like Yves said, I mean, enhancer. But we are not going to chase you any longer. My co-chairman would like to talk, and he's the next speaker. Thank you very much. So Francesco will talk about ABC ROLEX Main, individual patient data pool analysis.
So the first presentation, I mean, the previous presentation was showing the loss in statistical power when you go to subgroup, and this will show the benefit of putting together studies to have an increase in power. So the dual stenting strategies in unprotected left main PCI bifurcation group was part of the investigations into the EBC main trial and the ROLEX registry. These 2 studies were performed in high-volume centers from 12 different European countries. They were conducted almost contemporarily and used the same last generation using stent, so reducing the confounding related to the device. And the study protocols in both studies recommended to follow the EBC best practice for bifurcation stenting, either provisional or double stenting techniques. This is very important because this common study environment allowed to put together the data. And why doing this? Because evidence from the first drug-eluting stent area demonstrated that left main patients with greater anatomical complexity are requiring dual stent implantation during PCI, are exposed at higher long-term risk. We know very well this. And the majority of available evidence supporting systematic two-stent strategies with specific techniques has originated from Asian studies conducted by very expert DKA crash operators enrolling patients with very high anatomic complexity. So it is not, obvious that this data can translate into the European environment. So the study design of for this analysis was to put together the individual patients' data into a single database from these 2 studies. And the bifurcation PCI conduction was classified according to the MATS2 classification. And the predefined bifurcation stenting comparisons were among bifurcation PCIs, 1 stent versus 2 stents, to see if it is true that there is an hazard with 2 stents. Within 2 stent PCI, crash versus T-tap versus culotte, I really emphasize that there are no direct comparisons between these 3 techniques altogether. And within T-tap and culotte, the implantation of the first stent into the provisional or inverted provisional A or inverted A into the MATS classification. The study endpoints, all events were adjudicated by the independent adverse events committees of the individual studies with no further re-evaluation and discussion. Statistical analysis were performed by an independent statistical team, and primary endpoint was measured adverse events at 2 years that included all-cause death, myocardial infarction, and target vessel revascularization. These are the characteristics of the entire study population and the 2 groups, left main bifurcation 1 stent, almost half and half were the 1 stent and 2 stents. We put together 960 patients undergoing unprotected left main. That is actually one of the largest series of prospectively treated patients with bifurcation on the left main, and the number of patients with 2 and 1 stent is the largest ever analyzed in this kind of analysis. So there were no measured clinical differences between 1 and 2 stents except for body mass index. Regarding the angiographic features, as expected, there was a higher SINTA score and enhanced complexity in the subgroup of patients of two-stent group in terms of Medina through bifurcation, severe calcification. So all the adverse features were higher into the two-stent group. And regarding the PCI characteristics, here are reported. I just emphasized the fact that there was a similar attitude in using intravascular imaging, IVUS or OCT, around 40–44% in the two groups. Regarding the technique that we applied, honestly, they really reflect the truth of the practice in Europe, because the vast majority of the patients received two stents in the course of A or inverted A, ending up with a T-tap or culotte. And on the other side, there was the possibility that inside these high-volume centers, there were some operators that were committed to DK crash techniques, so that we had a subgroup of patients who received the stent, both implanting the crash technique, both implanting the first stent into the side, but sometimes also an inverted way into the distal main vessel first, and the second in the left main towards circumflex. So, regarding the 1 versus 2 stent techniques, this is the clinical outcomes we noticed. There is a significant adverse outcome for the dual stent group that, splitting by the individual component of the measured adverse events, is driven by a significant increase of target vessel vascularization with no major issue in terms of mortality. Regarding the angio or imaging guided guidance, I think that this really allowed to have an hint regarding the possible impact, because in the angiographic guidance group, there was a statistically significant difference between a single and dual stent outcomes. On the opposite, in the image guidance group, there was similar outcomes for patients. I think that this really deserves attention. It seems that imaging can a little bit blunt the adverse risk of the increased risk of dual stenting procedures. And here we have probably something that we really want to know, if the different technique, if practiced by an operator that trusts in it and follows the EBC recommendations, can have similar outcomes. So we had 40 patients treated by crash, 146 with T-tap, mainly tap, honestly, and 183 by culotte. And there was no clinical differences between the two groups on the baseline, and the angiographic features were broadly similar, except for a lower SINTA score in the crash group and a higher prevalence of true bifurcation in the culotte group. These were the only significant difference. And these are the outcomes. There are completely no signals for differences, and this is the sub-analysis according to the individual components of the primary endpoint, showing remarkably similar outcomes. Last thing is, since in Europe the T-tap and culotte are used to deal with the complex left main patients, it will be extremely important to understand if the implantation modality may change the outcome. The number of patients treated was 174 for T-tap and culotte, and 155 for the inverted provisional double stenting. And this is the outcome. Again, no difference in any of the analysis. So if we look at the predictors of measured adverse event in the dual stent PCI, trying to understand if there is some technical aspect that influence the outcome, here is the univariate analysis and the multivariate analysis, showing that only age and impaired ejection fraction impacts in dual stent PCI, while the technique and the baseline features do not. So it seems that there is no measured impact for the technique, and the clinical aspects are probably more important. So, in conclusion, my perspective are that this pooled analysis of the EBC Main and ROLEX trials provides the largest European experience of unprotected left main PCI with contemporary drug-eluting stent. Dual stenting identifies higher risk subgroup, but outcomes are independent of specific to stent techniques when procedures are performed according to expert recommended steps. And these findings shift the emphasis from technique selection to procedural rigor, reinforce the value of intravascular imaging, and provide contemporary evidence to guide clinical practice in left main PCI. The special thanks comes to the two PI, Hildik and David, and also to the younger colleague that helped us in running this analysis. Thank you.
Francesco, you can stay there or you can come here.
I can come.
Okay, good. So, sorry, can we see one slide back? The slide of the two-stent survival probability. That's, yeah, a few slides back. This one, yeah, of this one doesn't match to. I mean, it's quite interesting. You have big numbers there in terms of patient. There is something happening at 180 days in the dual stent. Do you have any explanation for that?
Explanation, the only explanation I have comes from the experience of the syntax extended survival analysis you provided. The syntax teaches us that the detrimental effect of having two stents inside the patients may take time to appear. I don't think that there is something specific happening. There is probably something that is just the accumulation of things. I mean, there are patients who will withdraw the double antiplatelet therapy. There is also the start of development of
I was
restenosis
thinking about, because
so
you
on.
don't have any angiographic follow-up in this population, so it is really a natural
yes.
course of the event. It's a death there. It's a survival probability. So I was thinking, hey, is there something with the platelet there which is taking place?
Anyway, both the trials recommended to have at least 6, but the vast majority of the patients received 12 months DAPT, honestly, in the trial.
Okay, question. Oh, sorry, go ahead.
Francesco, the separation of 6 months, was that self-reported events, or was the coordinator calling these people to see if there were adverse events in 6 months? Because you didn't have a follow-up, routine angiographic follow-up at that time, right? Was it self-reported issues that came along at 6 months?
Yes, honestly, both studies did not recommend it to perform any kind of systematic evaluation, even clinical evaluation. It was, I mean, the treatment was done in the cath lab, and then the follow-up was recommended. So what happened was done according to the local practice of the different centers. So, and I think that 6 months is also the period when restenosis starts to become clinically apparent.
Thank you very much.
At the back there, I think there was two person at the back, no?
Let's start with the one with the microphone.
Yeah.
So right on the next slide that we just saw, when you separate using imaging and the not using imaging in 1 and 2 stent technique, if I'm right, the absence of the difference in the using imaging technique was the higher rate of events in 1 stent technique. Am I correct? It looked like that. And also in the multivariable analysis that you put at the end, there was no information on imaging use. Can you elaborate the numbers of the rate of...
You see that in the hagiographic guidance group, there was difference between a single and dual stent events in terms of detrimental effect of dual stents. With imaging guidance, the two curves are the similar one. And in the in the multivariable analysis, since in the overall series of patients treated with 2 stents, it was not significant, it didn't enter, so the use of imaging.
Like the red curve, it's higher rate of events in the imaging guidance.
This is a survival probability. Yeah. So it is higher survival with single stent.
Yeah, I think when you look at mortality, which is very important, is really have the vital status. And it's easy to get the vital status in Europe. The FDA does not accept anymore something which is not with a vital status, okay? The question that you have to ask in the registry, in the national registry, is he dead? Not is he alive, is he dead? And you will get the information immediately. And you know, there was that paper in BMG in the state of California in a trial of 13,000 patients. The government of California knew the exact number of deaths, but the CRO was missing 267 deaths. Just because sending email and letter and so is not effective, the government, you cannot bury somebody without a certificate of death. So that's the best way to get vital status of all of them. And you have surprise, because the people lost to follow-up, the people withdrawing of the trial, that's the potentially death in the vital status of the registry. Very important.
Okay.
We go?
Thank you.
Okay, so I'll give you the card, and you announce Duk.
Yes, so next study will be presented remotely, I think, from Professor Park, and this is the POST-PCI trial, how to follow up complex PCI patients. We discussed during the discussion of this EBC main pooled analysis about the possibility to influence the outcome with our follow-up. Okay.
Hello, my name is Duk-Woo Park. I'm very happy to present the post-PCI trial, and thank you for inviting me in the EBC 2025 meeting. And today my lecture is about how to follow the strategy, the complex PCI patient. This is my disclosure. So, and our post-PCI trial was presented at the ESC meeting 2022 that was published New England Journal of Medicine 2012-22, and the routine functional testing was standard of care in the high-risk patient after complex PCI. So, and absolutely everybody know well, and PCI is a standard of therapy in ischemic heart disease. But after PCI, especially in the complex PCI procedure, and this is the important question: how do we follow the patient after complex PCI? And in many practice, and just based on clinical symptom, and just do ECG, and some center doing the very regular basis, the treadmill test and the nuclear imaging test, or sometimes stress echo. And the role of the non-invasive post-PCI follow-up surveillance, there is still the important question. And after publication of our post-PCI trial, and the Sunil Lao and his editor-in-chief in circulation intervention sent the message, and thank you, DW, and congratulations in your trial. And even in New York City, so many doctors get routine stress testing annually on the patient. I think he proposed, and the post-PCI trial provide the very important evidence for this field. And I think I feel that this is absolutely clinical unmet need in the universally, same in US as Korea, in all another world. So at the time of our trial, the conducting and the guideline recommended 2B recommendation in the high-risk PCI patient, and the surveillance of non-invasive imaging-based stress testing recommended 2B, and the routine non-invasive imaging stress testing may be considered 1 year after PCI was also 2B recommendation. So our post-PCI trial included 1,700 patient, high-risk patient undergoing PCI in real world, and the randomization 1-to-1 ratio. One arm is just the standard of care, symptom-driven evaluation using non-invasive or invasive testing, and the one arm is routine stress testing at 1 year post-PCI. Routine stress testing included exercise ECG, nuclear stress testing, or stress echocardiography. Also, we evaluated the composite primary endpoint at 2 year post-PCI. And our post-PCI trial involving high-risk anatomical or clinical characteristics, anatomical included the left main, bifurcation, OSTR or CTO, and the multivessel and diffuse long region. With regard to clinical characteristics, we included the diabetic and the renal failure or enzyme positive HCS population. So our trial adapted a pragmatic trial design, and we used the pre-existing real-world prospective registry, IRIS-DS registry. And the primary endpoint was at 2 year time point, and we evaluated the major cardiovascular event is composite of all-cause death, MI, or hospitalization for unstable angina, and the diverse secondary endpoint evaluated, including lipid revascularization or invasive coronary angiography. And overall, our trial included 1,706 and the 1-to-1 randomization, and the routine functional testing arm, and approximately 83% do routine functional testing at 1 year according to assigned strategy. And the standard of care arm, only 9% do, and the functional testing, that was mainly the depending on the clinical indication, new symptom, and the new the change of the clinical symptom. And the primary endpoint was there was no difference primary composite endpoint at 2 year, and the functional testing group is 5.5%, and the standard of care in the 6.0%, and the deaths of the mortality and the MI and hospitalization for unstable angina is no difference at all between two groups. And so our trial is concluded that routine functional testing, even after complex PCI, did not improve clinical outcome at 2 years. That was a key message of our post-PCI trial. Absolutely, is the practical conclusion. There is no need to spend a lot of money on the regular follow-up examination every year. You know, our medical, the clinic, the CHIP said, and the NEJM paper is really great, but I don't really favor for the result, and because of CHIP is considered as a financial problem. So our trial is editorial proposed, and the post-PCI can provide the compelling new evidence, class 3 recommendation. A couple of months later, our trial is adapted in the new guideline 2023 ACC/AHA guideline for chronic coronary disease, and in this guideline updated the inpatient chronic coronary disease without any change of the symptom, and the routine periodic testing using CT or stress testing was not recommended. That was based on our post-PCI trial is directly adapted the clinical guideline. And we did also very interesting subgroup analysis. This is mainly targeting left main or multivessel disease. And in our practice, left main or multivessel disease is a very complex disease. And even after successful PCI, and we are always considering which follow-up strategy is best for this patient. So that was published in JAG. And in the high-risk group, left main or multivessel disease, and we evaluate the overall outcome that is consistent with the primary result is the post-PCI trial. We didn't find any difference primary endpoint. That was consistent multivessel or left main disease, but the invasive coronary angiography or lipid revascularization was higher in the routine functional testing group. However, that was did not translate to the improving of the hard clinical endpoint. And in our post-PCI trial, we did a very interesting subgroup analysis in the looking at the bifurcation group, and we found, and even after bifurcation PCI, we didn't find any additional benefit with the routine functional testing. There was a consistent bifurcation region or no bifurcation region p-value for interaction is 0.24. And even according to number of high-risk picture, we didn't find any additional benefit with the routine functional testing. So, and we did some interesting analysis according to the diabetic that was published in the European Heart Journal, and our trial was certified the presence or absence in diabetic. Overall finding is very same. And although diabetic patient high risk of ischemic and clinical event, and irrespective of routine functional testing or standard of care, we didn't find any difference in the primary endpoint, and there was interpreted in terms of ischemia trial, and any aggressive routine follow-up, any aggressive invasive management did not improve the patient outcome. Absolutely, our trial in line with the less is more concept trial. So, and our trial also evaluated according to the with or without acute coronary syndrome. Overall finding is consistent, and although ACS population has a higher risk of a clinical event, and irrespective of routine functional testing or standard of care, overall outcome was consistent. That is means regardless of any clinical presentation, routine functional testing did not improve the clinical outcome. So, and the key summary, how to follow complex PCI patient, and the conclusion of irrespective of any region, bifurcation region, or left main, or multivessel disease, or clinical situation is according to diabetic or ACS, and the routine functional testing did not significantly reduce the risk of a primary composite endpoint, death, MI, hospitalization for unstable angina among high-risk population undergoing complex PCI as compared to the standard of follow-up strategy. And the routine stress testing after complex PCI was only associated with increased rate of invasive coronary angiography, and the repeat revascularization unfortunately did not translate into improvement of primary clinical outcome. Thank you for your attention. I'm very happy to involve this year EBC meeting.
So unfortunately, Professor Park was not able to reach us, even if he was intended doing, but we can discuss a little bit, because I mean, during these 2 days, we saw so many complex cases in the screen that I feel that this is important data we should incorporate.
So my first reaction is that 1 week ago, we were in Belgrado to the meeting of Goran, and the first speaker was Sunil Rao. And he emphasized that point, and I was puzzled by his conclusion. He said, as a first author and chairman of the guideline in USA, I would like to keep the recommendation 1 and 3. And eliminate the 2B and the 2A. There is something true there, because the 2A and the 2B is basically the clinical judgment. You can always argue, even in court, if you don't do A, you are possibly in trouble. I've been in court for helping cardiologists many times now, and 3, it's clear, you should not do it. But in between, it's free. So it's a gray zone, and I think that this debate will continue for some time, because now the diabetic is already out of the pictures. The second point is, what about 5 years? Okay, what about 10 years? Okay, so I can be sure that in the future ABC we will keep discussing that topic, how to follow the patient. And the disrupting element will be, of course, the non-invasive imaging. It will come in there. We already see that, yeah? Any question from the panel?
So one group that we have not talked about is the one with incomplete revascularization. You might have fixed the left main, but left a right coronary artery CTO alone. So do you really follow those? I mean, what happens? Because it's still revascularization incomplete.
Gutiérrez, you want to say something, no?
I wanted to make some remarks, and I think this is a very important study that gives us some evidence about, I mean, how to plan the future guidance. But I think the question is far from being solved, because actually in the subgroup analysis, there were some subgroups that tended to benefit from the functional test. Women, for instance. Women were about to be significant at the benefit of the functional test, probably because they seek for assistance later than the men, and probably you have to track them more closely. I don't know.
There will be a lot of 2A, 2B, believe me.
Yeah.
That's. Any question from the audience on this important communication?
And actually, Dr. Burzotta published probably 8 years ago the benefit of systematic and geographic follow-up in the left main.
Yes, I feel that it was a long time ago when it was the first generation drug-eluting stent. So I feel that the quality of revascularization you achieved during the procedure might influence. At that time, the quality of revascularization was poor because, for example, we didn't know the problem of geographic miss with drug-eluting stent. We didn't know it was a matter of first generation drug-eluting stent where we did not push the lot during the first procedure for stent expansion. So I think that, but still, in our cath labs, there are some patients who have low quality revascularization. That means stents implanted probably without an optimal results and a lot of incomplete revascularization. For this subgroup of patients, I still feel that some specific track should be adjusted. But anyway, this signal is strong because I was speaking with Patrick that one of the main issues we have, as soon as we have new devices, the fact that there are potential economic issues in introducing them into the routine practice. If we spare money from this kind of evaluation, stress tests, and so on, systematically done in low-risk populations, we will have more IVL in our cath labs, I think.
So Francisco, now we're getting to drug-coated balloons for native coronaries. How do you follow those? Do you follow those at all? Or because the way you go back to balloon angioplasty era, there's a lot of dissection and other things that we left alone.
That was what Andreas Grunzig called the dentist approach. You have today you do a one vessel disease in the RCA, 5 years later in the LAD, 5 years later in the circumflex, and you are permanently a one vessel disease. He stopped to say that at a certain moment because the people were a little bit critical about putting the patient too many times on the table. Yeah, I think that that question of follow-up will continue. Just as a historical anecdote, when we planned the syntax in 2005 with the main stem, there were in the ethics committee the obligation to make a control for the main stem. What we did at that time is that Antonio Colombo, myself in Rotterdam, and Marie-Claude Corris in Paris, we review all our main stem without control and came to conclusion that there was no risk. And finally, in the syntax study, there was no control of the main stem. So it's an old problem, almost 20 years ago, but in medicine, it is like that. I mean, it takes time to change. You have seen the remark of the chief of the department who say, I want to maintain the exercise testing. Why? Because it's a source of money. Yeah, let's put that way. His response. Yeah. Okay, we should move.
Yes, let's finish the session. Next and final presentation will be the AQUA2 trial. Andrea Erriquez is going to present it.
Thank you, Professor, for the presentation. It's a real pleasure for me to be here to present you the results of the AQUA2 trial, which investigated coronary physiology guidance versus conventional angiography for optimization of PCI. Well, we designed this trial because previous attempts to demonstrate the superiority of incremental optimization guided by wire-based FFR have yielded conflicting results. However, in the first AQUA trial, we investigated a plan guided by an angio-derived FFR pullback that has been proven to be feasible and superior to conventional angiography-based PCI, in terms of functional result of revascularization, although the result of the first AQUA trial was limited to low anatomical complexity coronary lesions. However, the implementation of pressure-sensing microcatheters may facilitate the application of systematic use of invasive physiology procedural planning and guidance, especially in complex lesions, including through bifurcations. So, with the AQUA2 trial, we aim to demonstrate the superiority of the physiology-based PCI over conventional angiography-based PCI in achieving a good and optimal functional result of the revascularization, also in patients undergoing chip procedure, including bifurcations. So this is the design. The AQUA2 trial was a multi-center, open-label, investigator-driven randomized control trial, which enrolled 305 patients with at least one chip criteria, who were randomized to conventional angio-based PCI or physiology-based PCI. And in the physiology group, patients were further randomized to two different tools of assessment, so the microcatheter-derived FFR or the angio-derived FFR evaluation with the AngioPulse system software, so the so-called MuFR. However, in all groups, patients underwent PCI with implantation of biodegradable polymer sirolimus eluting ultra-thin stents, and at the end of the procedure, invasive FFR with pullback was reassessed in order to obtain the functional result of the PCI. Okay. This is the schematic flow of how physio-guided PCI worked in the trial. On the left of the slide, we can see the microcatheter virtual PCI by the TruPhysio system, and on the right, the angio-derived FFR virtual PCI with the AngioPlus system. In both cases, we performed the pre-PCI assessment with the analysis of the pullback pressure gradient, invasively obtained or virtual in the case of angio-derived FFR. And on this basis, we performed PCI and then reassess the physiology with the same device in order to detect potential residual focal drop, because in that case, we had to optimize the procedure by adding a new stent or by performing a more aggressive post-dilation inside the stented segment in order to obtain a final functional good result. And the primary endpoint of the study was the superiority of physio-guided PCI as compared to the angio-derived PCI, angio-based PCI, as assessed by post-PCI FFR that was considered optimal when the value was above 0.86 based on previous evidence. Well, baseline characteristics were basically well balanced between the two different groups of investigation, and as you can see in this slide, true bifurcation was one of the main CHIP criteria present in about 50% of the overall population. Also, vessels characteristics were well balanced between the two groups without the significant differences. And coming to the result, firstly, we found out no significant differences between the two tools of functional assessment, so microcatheter-derived FFR and angio-derived FFR was basically comparable in terms of final result of the revascularization. But more importantly, we observed a significant difference between physio-guided PCI versus angio-guided PCI in terms of functional results. So with physiology application, we found more frequently a better result of the revascularization. And this result was consistent also in the true bifurcation subgroup. So also in true bifurcation, the systematic use of physiological assessment translated in a better physiological result at the end of the procedure. And in these last minutes of my presentation, I want to share with you two clinical examples of patients with true bifurcation randomized, enrolled and treated in the trial according to the protocol. So this first case is a quite tight lesion, focal lesion on a mid-proximal LAD with a huge diagonal branch. We perform the pre-PCI assessment that was obviously very low. So we performed our PCI with a provisional stenting, with a single stent on LAD, with a good result angiographically on the main branch. But as expected, we observed the pinching of the side branch ostium due to the carina shift after the main branch stenting. So what to do in this case? What to do next? Performing a kissing balloon, a two-stent technique? Well, in the trial, in our trial, before performing any other maneuver, we want to obtain the functional assessment of the side branch. So you can see in this angio, the microcatheter, the FFR device, easily passing and crossing the diagonal through the stent on LAD, and we were able to obtain the functional assessment of the diagonal that was very, very reassuring, very, very negative, and that reassured us to leave the diagonal in this way without the need to treat it with any other maneuver, because the flow was not limited, as confirmed and demonstrated by the high value of FFR on the diagonal. In this second case, we had to manage a left main disease involving mainly the LAD, but also the circ, as confirmed by the pre-PCI FFR assessment that was very, very low and very positive on both branches. But again, also in this case, we want to perform a provisional stenting, a provisional crossover stenting of a left main through LAD, and then to reassess the circ in order to guide the revascularization. So we proceed with the provisional stenting, and again, you can, oh, sorry, I spoiled. So you can see the microcatheter crossing through to the circ, and we were able to obtain the functional assessment of the circ. And in this case, the functional assessment of the side branch was not good, was positive. So in this case, we cannot be satisfied by a provisional stenting because the flow is limited on the side branch. So we need a two-stent technique. So we proceed with the bifurcation stenting on the circ, and in this way, we were able to achieve a good functional result also on the circ. So in conclusions, the AQUA2 trial demonstrated that the systematic application of coronary physiology was superior to conventional angiography in guiding and optimizing PCI procedure, also in patients undergoing CHIP, including bifurcations, in terms of achieving a good functional result of the revascularization. And especially in true bifurcation lesions, the microcatheter-derived FFR should be the ideal functional approach because it's very easy to use and safe in order to assess and to guide the strategy of the revascularization of the side branch, so in order to decide to perform a provisional stenting versus a two-stent technique. Thank you for your attention.
Okay. Questions?
Go ahead, first.
Congratulations for this piece of evidence, which is very relevant. I've noticed that you were doing wire-based physiology in the donor arteries of a chronically totally occluded RCA. You know that this might induce some bias, so it was not an exclusion criteria for the study, right?
No, it was not an exclusion criteria because we not decided to treat the total occluded artery, so the donor vessel is...
The wire catheter-based physiological assessment is probably going to go away more to angiography-based FFR. So what are your thoughts on that? I mean, I know you did the microcatheter work, but just for comparison, you didn't show us what the angiography-based FFR was following your PCI results. So you would tell us about superiority or non-inferiority. You didn't tell us that based on what you proposed in this trial.
No, in the trial, we found a non-inferiority between the two methodics. So the results were comparable between microcatheter FFR and angio-based FFR system. In particular, in some cases of complex lesions, in particular through bifurcations, we thought that the microcatheter device can be very useful because you can use it every time you want without losing the wiring position on the side branch. And so this is very, very useful and very safe.
So this is going to fuel the debate that we are going to see in 2026. Don't forget that Chubot published in The Lancet, and I'm co-author, that QFR was superior to visual angiography. Then you have the study of Neil Holmes, who said that FFR is more reliable than QFR. And at DSC, I present an interim analysis of Pioneer, because in Pioneer we were comparing QFR and usual care, okay? And you do what you want, what you do in reality. And of course, it's an interim analysis because we saw the percentage of QFR and the recruitment going down. And that's a very important impact for the community. So we consulted the DSMB, the steering committee, and they recommend after 60% of the patient analyzed that we present that to the community for safety reasons. And we did, and we have a classic Stuart Polcock penalty for double look, etc., etc. But I think that next year you will have FAST 3, which is the VFFR of Joost Dammen in Rotterdam. So that will be, again, is the FFR superior to the QFR? And you are in between there, okay? You must have a slight bias for the microcatheter, because when the people do a randomization 2-to-1 is because they want that the two win on the one, but that is detail. And I agree with you, I mean, you keep access, which is very important. I remember having reviewed paper about the fact that the microcatheter overestimate the gradient, because you limit some space by something which is what, 1 French of? Yeah, 1 French. So that's 2.33 millimeter, if I'm correct. So that increased the gradient. So I'm really curious where we are going, because in our experience, the QFR was absolutely not different from the usual care. But in the usual care, there were 41% of FFR, IFR, all kind of measurement with the pressure Y. Why? Because in the guideline, it is a recommendation 1A. So if you do usual care, the people will do these things. Not 100%, but they will do the use of it. So I think it reflected the reality, and I think the debate is still open, yeah?
And also, if I want to add a comment, it also shows that the feasibility of having a PCI physiologically optimized. So if you open up the catheter for measurements before, it is also important that we use it at the end. Thank you very much. Congratulations. We have finished. And in the interest of time, we close the session. I hope you enjoyed, and there is just a panel exchange with no break. Thank you very much to everybody.